Gunawardana, Professor in Oncology and Senior Consultant Oncologist, Faculty of Medicine, General Sir John Kothalawala Defence University, Sri Lanka, and the Chancellor of Uva-Wellassa University to deliver his speech on oncological management of pancreatic cancer.
This one. You can see over here. Good evening. At the very outset, let me thank the President and the Council of the College of Palliative Medicine in Sri Lanka for giving this opportunity for me to join this symposium. And Samadhi, congratulations on your excellent oration on this exceptional personality. It was very well done. And Ranga did 75% of my lecture, and Densil did the other 25%. And Prasadini was very sympathetic towards me. She did not encroach into my territory. But anyway, I believe repetition is emphasis. So let's start all over again. Right. Pancreatic cancer is a potentially curable malignancy if detected early. And the place of screening is rather unclear. The old age is the strongest risk factor. The 70% will carry spontaneous somatic mutations. When I say somatic, they are not there in the germline, they are in the somatic. So it's very difficult to check the blood and detect them. But small proportion can be due to germline mutations. There's an entity called familial pancreatic carcinoma, where at least 2 first-degree relatives are affected. The incidence is only about 4 to 10%, very limited. And there, the BRCA mutation is the commonest germline mutation. So there are certain causative factors for sporadic pancreatic cancer: the tobacco, Samadhi's enemy, and H. pylori infection, and high red meat intake, and also high alcohol consumption, and reduced fruits and vegetables in your diet, obesity, one of the strongest risk factors, and type 2 diabetes, and also chronic pancreatitis due to any reason. The important thing is most of these things are modifiable risk factors. So when you say high-risk patients, they can be subjected to certain degree of screening in very special scenarios by using endoscopic ultrasound scan as well as MRI. So usually we start them from 50 years onwards, and it is very important, if you have a family history, to start this screening at least 10 years before the youngest member affected. Now, for instance, if the youngest member in the family who got affected was for 50 years, then you have to start at the age of 40 years. So that is the rule. 75% do occur in the head of the pancreas. Ranga mentioned about that. Another 25% occur in the body and the tail. The head of the pancreas are diagnosed pretty much early than the rest because they give symptoms early due to obstructive features, the bile duct obstruction as well as the pancreatic duct obstruction. So these are the common things. Again, Ranga described in a comprehensive way. Icterus, abdominal pain, which is very characteristic, even during medical time, they used to teach us. So it is aggravating when you are lying down and can be reduced by bending forward, classical pain, and the loss of weight, and steatorrhea, fatty stools, and worsening of pre-existing diabetes mellitus for no reason, and duodenal obstruction as well in advanced cases. So imaging, now I'm going to Densil's entity. CCT, chest, abdomen, pelvis, is mandatory, and we ESMO guidelines very clearly say to do multi-phase CECT. That is the best to study about the vasculature in and around the pancreas. So there are 4 important vessels: superior mesenteric artery, superior mesenteric vein, the portal vein, as well as there's another one which I can't remember. What is the other one, Ranga? So, yeah, aorta. So there are some direct signs like hypervascular tumors, and there are indirect signs like pancreatic and bile duct dilatation. So those are important when you are doing radiological assessment. The MRI is the best modality to assess the liver status, and that can be combined with MRCP, and the ERCP is another reliable investigation in diagnosing pancreatic malignancies. And the presence of double duct sign is pathognomonic, that is the enlargement of both ducts, bile duct as well as the pancreatic duct. That is called the double duct sign, which is very characteristic in pancreatic malignancies. Again, when you discuss further about imaging, endoscopic ultrasound scan is a new modality that is ideal to verify isodense tumors on the CECT where there are doubts, and it is also useful in taking biopsies from the tumor itself and from the surrounding lymph nodes as well as from the left side of the liver. It's a very safe procedure. And the PET scan, as Densely said, it is not a diagnostic tool, but it is a staging tool. So you don't depend on PET scan for the diagnosis, but it is important for further staging and to follow up the patient and to detect early recurrences. And when we look at the histology, it is best to have histological diagnosis if chemotherapy or chemoradiation is planned. So those are oncological management. If you are planning chemotherapy or chemoradiation, it is mandatory to have a histological diagnosis. But having said that, for resection, it is not mandatory. For resection, you can go for resection without a histological diagnosis on doubt. One may begin treatment without a tissue diagnosis in following scenarios, right? But having said that, you need to have a good MDT discussion with the tumor board and good imaging conclusions to make sure that it is a pancreatic malignancy, and the relevant symptomatology, which is specific for the pancreas, and ultimately biochemical parameters like CA19.9 elevation. So if you have those parameters, one can safely go in and do the surgery without a histological diagnosis. If you look at the pathology, again Ranga said this, 95% of them are extraendocrine pancreas, another 5% can be endocrine tumors, and the 2% of extraendocrine tumors are benign. So you get benign entities as well. And ductal adenocarcinoma is the commonest extraendocrine tumor, which will account for about 80%. And there are other types like adenosquamous carcinoma, rare though, undifferentiated carcinoma, once again rare. And there's a category called acinar cell adenocarcinoma, which has a good prognosis. It has a fairly good outcome if you diagnose that category. And there's another category called cystic neoplasms. You always find cysts in the pancreas. So it can be 10 to 15%. There are various categories: serous cyst adenomas, benign, then intraductal papillary mucinous neoplasm, IPMN. It's another category. And the mucinous cyst adenomas or cyst adenocarcinomas. The important thing here is most of the non-mucinous cystic lesions are benign. But whenever you see mucin, they are potentially malignant. So mucinous ones you cannot ignore by any means. Okay. So cystic ones you may follow up, but the mucinous ones you need to intervene early. Then it has a lot of genetic alterations, pancreatic malignancy, which are important in your diagnostic and the predictive and the prognostic value, right? So genetic alterations are seen in more than 90%. They are mostly KRAS mutations, right? And there are other mutations like tumor suppressor genes P53. So that is important. Whenever there is a P53 alteration, the outcome becomes very poor. That is a bad prognosticator. Then you get the mismatch repair genes, right? And other important thing is HRR, that is homologous recombination repair gene, HRR gene, like BRCA1 and BRCA2. Very important in your further therapy, especially when you are managing metastatic pancreatic cancer. Now those, which I have mentioned on the others, they are mostly germline mutations. So they are with blood, you can check the germline, because when there is germline mutation, that is they are in the blood as well as in the tumor. When there are somatic mutations, they are only there in the tumor. Okay, so you are going to miss a lot of things. somatic mutations if you are only going to do the blood, but when you do the blood, germline mutations can be detected easily. Then there are other genetic alterations. There are two parameters you need to know: MSI, that is called the microsatellite instability, and the TMB, tumor mutational burden. They are very important because if the MSI is high and if a tumor mutational burden is high, more than 20%, so that gives us a chance to treat these patients with immunotherapy. Expensive though, but there's a chance. They are the potential candidates for immunotherapy, right? That is the novel treatment. That is the future in oncological management. Okay, so this is not only applicable to pancreatic cancer, any solid tumor which has a high MSI and high TMB, they are potential candidates for immunotherapeutic manipulations. When you look at the biochemical markers, CA19.9 is fairly specific. It is elevated in about 80% of the cases. This is important. It is not seen with patients with Lewis antigen positivity. There is a special antigen in the body called Lewis antigen that is on the red blood cell, in the human red blood cell, which is the only antigen which is foreign to the red blood cell, which is being produced somewhere else and get absorbed to the red blood cell, right? So that is called Lewis antigen. So whenever there are patients who are Lewis antigen positive, you can't depend on your CA19.9. Okay, so it becomes invalid. And again, preoperative elevation of more than 500 units per ml indicates poor prognosis even after surgery. So that is a very important parameter. So what are the factors influence treatment? One is anatomical site, obviously, the size of the tumor, the TNM staging, and the nodal state. Right. The biochemical CA19.9 more than 500 is again a bad prognosticator, and performance status, because most of these patients, they lose weight and they become moribund if you don't start treatment early. All right. These are the indicators of poor survival: low performance status, age more than 65 years, low albumin less than 35, the presence of other synchronous metastases elsewhere, and the presence of liver mets, the number of metastatic sites, because there are two categories: real metastasis and the oligometastasis. If you have less than 5 metastatic sites, you call it oligometastasis. That is better than having frank metastasis and heavily elevated CA19.9. So all these factors can be considered as poor survival indicators. When we are trying to decide about the treatment, there are 4 categories we have identified: the resectable category, the borderline resectable category, the locally advanced category, and advanced and metastatic category. So their treatment differs depending on the type. Right. If you look at the resectable disease, the surgical resection is the only potentially curative treatment option. But when you are doing that, you need at least 1 millimeter free margin to call it R0 resection. In surgery, there are 3 kinds: R0, R1, and R2. R0 is complete resection, no residue. R1 is microscopic contamination. R2 is macroscopic contamination. So to have a R0 resection, 1 millimeter margin is adequate, right? And attention should be given to superior mesenteric artery, superior mesenteric vein, celiac axis, and the portal vein. Right, as Ranga said very clearly, very correctly. Now those days involvement may, indicate, inoperable status, but now you can even resect part of the artery of the vein which is affected and sort of repair them in a very special way. So type of resection depends on the site. The head of the pancreas, you do the pancreatic duodenectomy, Whipple's operation. The body and the tail, you can do the distal pancreatectomy and splenectomy. Right. Now, when you are trying to do surgery, most of the surgeons prefer open surgery to laparoscopic surgery because there's a better vision. But having said that, now the robotic surgery has replaced both. When you are trying to do robotic surgery, that will give a huge, magnified picture through the robotic arm, and there the resection will be pretty much easy. And when you are doing the primary surgery for resectable disease, we expect the surgeon to remove at least 16 nodes or more. Then only you call it a proper lymphadenectomy. The chronological age is not a contraindication for surgery. There can be guys who are in unfit 20s and fit 90s. Okay? So age is immaterial. So it is how you assess the patient, general condition. And avoid surgery in very moribund patients and with poor performance status and severe malnutrition. So you must select your patient properly before you embark on surgery. And if the patient has high bilirubin level more than 14.6, you can even consider preoperative drainage of bile before you embark on surgery. Then what are the adjuvant treatment in addition to surgery in resectable disease? So there are various trials done. One is called the SPAC1 trial. It shows benefit of adjuvant chemotherapy after surgery. Then there is CONCO 001 trial, benefit of a drug called gemcitabine on adjuvant basis after surgery. Prodigy 24 trial shows FOLFIRINOX. That is FOLFIRINOX is a combination of oxaliplatin, irinotecan, folinic acid and 5-FU. It's a fairly toxic regime, and that trial very clearly shows it is better than gemcitabine and nanopaclitaxel. So more toxic but better overall survival, right? But you need to select the patient properly. You can't give this sort of aggressive chemotherapy each and every patient. You need to select your patient properly with all the other parameters. How long are you going to give adjuvant treatment? It is recommended, the ESMO guideline is to at least give 6 months of adjuvant treatment after primary resection is complete. A good primary resection, right? Then the second category is borderline resectable pancreatic cancers. There you can't use surgery at once. You need to use some upfront or neoadjuvant, or you call it downstaging, foundation, cytoreactive, whatever. There are so many. Neoadjuvant is a bit of a cool term we are using nowadays. So you use neoadjuvant chemotherapy to downstage a tumor, right? So PREOPANIC-1 trial shows significant improvement of overall survival and disease-free survival and local regional failure from induction chemoradiotherapy and radiotherapy together. So when you do the induction treatment in borderline resectable disease, that will give you a better rate of R0 resection. You can do a better resection with clear margins, and that will improve your overall survival as well as disease-free survival. So there is a definite advantage of using neoadjuvant or upfront chemotherapy or chemoradiotherapy. So this is the flow chart or the algorithm. Preferred option is use chemotherapy in borderline and then followed by chemoradiation. Chemoradiation, you use radiotherapy and chemotherapy together concurrently at the same time, and then go for surgery once you have downstage a tumor in an adequate manner. So this is not very important for you all. Chemotherapy regimes, there are so many regimens, FOLFIRINOX is one, then gemcitabine, nanoalbumin, paclitaxel called the GN schedule is another one, gemcitabine, capecitabine is another schedule, and gemcitabine, oxaliplatin is another schedule. There are various schedules. When you are using chemoradiation, you are using radiation with concurrent capecitabine. Capecitabine is an oral tablet. So you give both together, okay? So these are various schedules that we can be used in induction treatment. Then you get the locally advanced pancreatic cancers, right? 30 to 40% they seem unresectable due to vascular involvement. That is why you call it locally advanced. And again, you can use the induction treatment, which will increase the possibility of resection and improves overall survival, right? You can use either chemo alone or chemo followed by chemoradiation, like in the previous case. That will improve the pathological complete response rate, and that will also given for 6 months before you do the embark on surgery, right? So till you get a good clearance with radiology, you keep on giving chemotherapy, and then once you are happy, once you are satisfied with the reduction of the downstage of the tumor, then you can go for surgery, right? Locally advanced pancreatic cancers, surgery is considered after induction only if significant reduction of T stage is seen, significant reduction of CA 19.9 is seen, and the significant clinical improvement is seen, right? So for this, you have to have an MDT. You can't say I'm a jack of all trades and I don't take decisions individually. You need to have a teamwork. The team will decide whether the patient is suitable for surgery, okay? That should be every every patient should be discussed in the tumor ward. That should be the correct management for pancreatic tumor, or for that matter for any tumor, but especially in this scenario. Then you get the advance in the metastatic pancreatic carcinomas. Is more or less incurable, right? If the performance state is good, 1, and the bilirubin level is less than 1.5, you can go for FOLFIRINOX as the first line treatment. Toxic schedule, but you can go for it, provided the patient has good PS and the bilirubin level is less than 1.5. Right. Right. When you consider FOLFIRINOX with GN, that is gemcitabine and nab-paclitaxel, the higher activity with FOLFIRINOX, but higher toxicity. So FOLFIRINOX is a more effective treatment schedule than GN, but at the cost of higher toxicity. Right. Now there's a better one called NALIRIFOX. They are using liposomal irinotecan instead of normal irinotecan, oxaliplatin 5-FU. That will give significantly better PFS and OS. Right? So that is the standard of care nowadays in centers where you have facilities to manage, adverse effects properly. Right. Now, then the second category is, again, if the patient is having PS of 2, little less than the first category, and still the bilirubin level is less than 1.5, you can use gemcitabine and nanoalbumin paclitaxel, called the GN combination, which will give it, because their FOLFIRINOX can be rather toxic in this setting. There can be another category where your PS is 2 or more, but bilirubin level is now more than 1.5. There you are using only gemcitabine as a single agent monotherapy. So you don't go for combination therapy. So you need to assess the patient properly and decide your treatment protocol. Now second line treatment, that is after initial gemcitabine based chemotherapy, right? If the patient is not responding, you can use liposomal irinotecan combination. They are better. That has been shown in Napoli 1 trial. These are all trial based recommendations. Then in advanced or metastatic pancreatic cancer, where there's a poor performance status and poor nutrition, you have to go for the third line treatment. That is basically single agent gemcitabine. You never use combinations, and then you have to go for the other supportive things like best supportive care, exercise to prevent cachexia and sarcopenia, and to induce thromboprophylaxis, because they can get various thromboembolic episodes, and replace pancreatic enzymes. Then in advanced and metastatic carcinomas, 5 to 7% are BRCA mutated, HRR mutated, okay? And most of them are germline mutations. You can detect them in blood, all right? So after initial chemotherapy, they can be put on so-called PARP inhibitors. PARP inhibitors as maintenance therapy. After initial induction, you can put them on a PARP maintenance. There's a drug called olaparib, then another called niraparib, rucaparib. Those are all PARP inhibitors. They block the enzyme. They block the enzyme PARP. So that will prevent sort of chromosomal repair, genetic repair, and that has been very clearly shown on Polo trial. So they are benefited by giving olaparib as maintenance therapy. Okay, so that is why we need to do all this genetic analysis, genomic analysis, or next generation sequencing in all these patients to find out possible targets for future manipulation. I think I covered things fairly okay, and thank you very much for your attention.